But welcome to those of you who are already on, and thank you for joining us. I'm Dr. Singh Pallet, and this is our monthly meeting for CMDA. We're very glad to have this chance to meet together and listen to some really wonderful speakers. And before we get started, I wanted to remind everyone that our CMDA annual conference is coming up in April 29th. And if you haven't registered, please go ahead and register and take a look at our website at cmda.us. We've got a wonderful full day of education and wonderful presentations and speakers. Because of our audience today, I can also mention we have the president of the American Society for Consultant Pharmacists coming into town to give us a presentation, and Chad Wars will be leading that. And he looks forward to meeting some of the local pharmacists and people who are part of ASCP. Our conference will be requiring vaccinations and boosters. We will have a masking policy in place. So we hope that anyone who can make it live will come to join us. But if you're not coming in live, go ahead and join us virtually. That'll be wonderful too. And before that conference, we actually have the National AMDA conference in Baltimore. That starts next week. And we are hoping to see some of our local Colorado and Wyoming folks there. And CMDA will actually be having a reception on Friday evening in Baltimore for that conference. And we invite anyone from Wyoming and Colorado and all of our colleagues to come join us. And just like the CMDA conference, that conference requires proof of vaccination for COVID, and we'll have a requirement for masks, and we're going to encourage social distancing as much as we can. So come one, come all. Can't wait to see you at the conferences coming up. And let's go ahead and get started with our agenda for today. Our first update today comes from CHCA. And Jenny Albertson is always so gracious with updates and knowledge for us. So why don't you go ahead and take it away, Jenny?
Good afternoon, I guess it is now, everybody. Thank you for having me. I'll give you just a quick overview here for a couple of minutes. We did have an American Healthcare Association update yesterday, so I wanted to give you a little bit of a national view for a moment on our industry. It looks like healthcare employment levels, there's been a new study released that indicates that it declined from mid-2020 to 21.1 million jobs in our sector. And that's a 5.2% decrease from 2019. So I wanted to let you all know that that data is out there now. And skilled nursing facilities specifically saw the largest decline of any healthcare venue at 8.4%. So most of the other employment levels in healthcare sectors have rebounded to pre-COVID levels in 2021 and are continuing to rebound in 2020. Oh, sorry about that. I think the mute button just came on and off. Okay. And that study is available through various news outlets, but I believe it was published in JAMA. Let's see, what else is interesting for you all? If you have facilities that you're directly interacting with as a medical director, you will see that their reporting is going to change in April for NHSN monthly data reporting, and there's a special access they have to have in order to get that deep into the reporting process. And so if they have not gotten their SAMS level 3 access, they may see a disruption in their ability to report, which could result in a deficiency for the NHSN reporting. So please be aware of that as you're participating in QAPI meetings and so forth, that it can be a 4-week process to get that level of access. So we're asking people to do a 3-person deep access for SAMS level 3, because we know how turnover and COVID cases can disrupt somebody being capable in the building to enter that data. So that's our regular data entry that we're doing around COVID.
Hey, Jenny.
Yes.
Hi, sorry, this is Deanna Curry. I just wanted to give you an update on that NHSN because they've changed it.
Oh.
NHSN has sent out last week they sent out and said they're delaying that reporting planning until September because they didn't have they're not ready. So anyway, that reporting planning, that level 3 reporting planning isn't happening until September. And I also learned this week that now there's a new way for people to get their NHSN access. They can actually go through a credit check kind of reporting instead of doing notification and proof of ID. And they actually have an app now that you can put on your phone instead of the grid card they were sending out. So it's supposed to take a week instead of 4 to 6. So all hot off the press. Just thought I'd let you know.
Thank you, Deanna. I appreciate you being wingman here. Thank you so much. Just a quick update on the vaccine mandate. Most of us were eagerly awaiting a permanent rule on February 16th. Just a quick reminder that those changes that they were to be approving and reviewing on that meeting, those were shelved until a later Board of Health meeting. So even though that impacts the reporting piece that we were just talking about, not NHSN specifically, but the frequency of reporting for facilities for vaccination with the EM resource was supposed to decrease to monthly with the permanent vaccine rule, but they did not review it in February, and they will have to postpone that for a future meeting. There was also supposed to be some updates to the language around fully vaccinated, policy and procedure, referencing the mitigation guidance and booster policies. All of that stuff is pending now. So just remember that the vaccine mandate was approved as it stood in December, and we haven't really made any substantial changes to it. And along those lines, boosters are not yet officially required. They have hinted that they will be incorporating that into the RCF mitigation guidance as a new description of what fully vaccinated is, but they have not yet rolled that out. I check it probably 3 times a day because they'll sneak in the RCF mitigation guidance updates and not alert us until a day later. So as of this morning, there is no update to that since January 25th. So we are still at the current definition of fully vaccinated as not including a booster. That said, there are local health departments enforcing a different definition. And if that does happen at your facilities, please alert me or somebody at CDPHE so that they can run interference for you, because they do want to be singing from the same hymnal. It's very misleading for local health departments to be implementing changes ahead of CDPHE, and they're not in favor of that either at the Epi folks. And I think that might be the last tidbit, because I think Chad is here to give his own updates on CDPHE and all of that. So thank you very much.
Thank you, Jenny. I didn't know you were checking the guidance 2 or 3 times a day. Now that is dedication. I appreciate you watching out for us. And Chad Fear is here from the CDPHE. He's the Nursing Facilities Section Manager. And this morning, I was able to join the quarterly nursing home roundtable with a great group of participants, and Chad led a great meeting today. Hello, Chad.
Good afternoon. Yeah, so we're kind of waiting as well, I guess I should say, for all of the updates that need to come through. I know that changes to the RCF mitigation guidance have been discussed, and they are putting clearance in. So we would not enforce anything that's not been released yet. As Jenny had mentioned, there have been some mention of those changes and expectations that have been shared with some facilities, and we've been able to clarify that for the facilities with Epi, that it definitely will wait until it's released before we hold that expectation. As it was mentioned in this morning's meeting that you referenced, we continue to try to deal with our backlog of surveys, both recertifications and complaint surveys, and all the while trying to keep those backlogs from growing with facilities that are, surveys that are not overdue yet. So we've got quite the task ahead of us, but I believe we'll meet that challenge and be able to make some progress. Time frame for that is to be determined for sure. I did pull some information that might interest some folks. We've seen I guess some consistency in the types of citations that we're seeing as a result of our inspections, but I believe the prevalence, the rates of those are going down significantly, such as infection control from fiscal year 21 to fiscal year 22 has citations for that have dropped significantly. We've seen a significant drop in the citations around the CLAPI and that process, focusing on those things that are centered around adverse outcomes, immediate jeopardy, that kind of thing. We continue to see immediate jeopardy has continued for since our last meeting for facility-acquired avoidable stage 4 pressure wounds. We're seeing continued issues with accidents and abuse, to name a few. Again, we've seen a drop in the rate of citations. So, we find that encouraging. I think, one, we are, developing consistency within our group in terms of how we're looking at that, as well as seeing some, the gains that facilities are making in addressing those things that have been identified. Really, and I won't go into great detail because I think there's still more to come, but the elephant in the room this morning was, and I think will continue to be until we get more information, is the press release from the White House and looking at a broad plan to quote unquote crack down on unsafe nursing homes. And so that's going to be something that's going to be rolled out, I think, over the course of time, and looking to see what that's going to consist of. But one thing that does stand out to me as a challenge for the system is looking at some required staffing rates and some oversight and concern related to that. So yeah, again, without going into too much more detail, and I'm sure much more is going to come out related to that, that's pretty much what I have for you today.
Thanks, Chad. Definitely appreciate the update and appreciate you also being available to us from our side. There is a question in the chat box for you, actually. Maybe you could answer it. Will Chad's slides from this morning be available to this group? They were great. And I agree, they were. And anyone who wasn't on that meeting today with the Nursing Home Roundtable, Chad made a really great statement about appreciating the nursing home staff and all the great work that's been done in our facilities over the past year, even sometimes when our staff members don't feel very appreciated. So, okay. Why don't we go ahead? Oh, did you want to go ahead and address that, Chad?
I do, just real quick, Margaret, we will try to get those slides out to everybody. And for Margaret, everything's available for a price.
Thank you. All right. Well, we have our clinical presentation now. This is on the COVID-19 treatments, COVID-19 therapeutics, navigating recent updates and drug-drug interactions. This will be presented by Dr. Kristina Brooks, PharmD, Assistant Professor at the University of Colorado, and Mitchel Dobro, a pharmacy student. Thank you guys for being here.
Great. Sorry, I had to get off mute. Thank you for having us. We're really excited to present today and thankful for the opportunity. So today I'll be covering COVID-19 therapeutics, navigating some brief recent updates. We were just discussing there are many that came out on Friday, and then drug-drug interactions, specifically with Paxlovid. Here we go. Okay, so for today, I'll briefly review current available COVID-19 therapeutics and recent updates in that space. Then we'll move into a discussion of how to manage drug-drug interactions with COVID-19 antivirals with a specific focus on Paxlovid, which is the generic is nirmatrelvir ritonavir, mouthful. And then I'll hand it off to Mitchel Dobro at the end to provide a quick debunking of controversial COVID-19 therapies, just because they seem to come up over and over. So we just wanted to quickly, hopefully, knock some of those out. So for COVID therapeutics, there's kind of multiple categories that you can think about. So there's anti-inflammatories that are targeted at modulating immune responses, and those are kind of like later on as disease progresses. And if you haven't caught it in time to treat with either the monoclonal antibodies or antivirals, So the monoclonal antibodies, they bind directly to the the COVID virus to neutralize the virus, whereas antivirals, they're generally targeted a bit later on at inhibiting viral replication downstream. And we'll mainly focus on the monoclonal antibodies and antivirals today. So for the monoclonal antibodies, there's a figure on the right just showing how exactly they work, but they're generally have been targeted at the SARS-CoV-2 spike protein, so on the outer surface of the virus. But it's important to keep in mind that this is where most of the COVID mutations have been happening over time. So this is what kind of dictates the ability to use certain monoclonal antibodies that I'll cover in a couple slides. So usually for the antibody treatments, they're generally indicated in adults and adolescents with mild to moderate disease and at high risk for progression to severe COVID-19. Generally, they're not indicated for use in hospitalized patients or those requiring oxygen therapy or respiratory support, or those with increased baseline oxygen needs. Generally, at that point, their disease has progressed a bit further where the monoclonal antibodies aren't likely to be as helpful at that stage. And another component, getting back to the comment on the ability to use with variants, their use is limited to those likely to have been infected with or exposed to susceptible variants. So it's important to keep in mind locally what exactly you're seeing in terms of variants and how common certain ones are. And generally for all of them, you want to monitor patients during administration for at least an hour after the end of the infusion administration. The reactions, they're fairly rare overall, but they can happen. So this is part of what feeds into that recommendation to monitor. So in getting at this increased risk of severe disease, I'm sure you are more than familiar with a lot of these conditions, but there's a lot of different disease conditions, a lot of chronic conditions that have been, that are listed here that can increase the risk of severe disease. So it's important. So I have the link in the bottom right-hand corner, and it seems like these have pretty much stabilized over time in terms of, of what exactly is included in the list, but older age over 65 is an example, cystic fibrosis, diabetes, disabilities, HIV, immunocompromised patients as examples. But it's important, if you have these patients coming in and you're aware of their other chronic conditions, just to be aware of what could put someone at increased risk, because that then helps inform what exact treatments you then, or how exactly you progress with treating with COVID. So here, this is a table just showing, getting at the point of monoclonal antibody efficacy against the current variants. So what's been happening over time is that usually as new variants are identified and become more common, then this is where they'll try to do assessments in vitro to see if available antibodies, if they're still able to bind and to neutralize the virus with those new mutations present. So this is part of why, recommendations have recently changed for bamlanivimab and casirivimab as examples. There's a huge fold change in the ability to bind to and neutralize the virus. So that's why those are no longer on the table anymore. So I'll just focus on sotrovimab in the middle column, bebtelovimab, and on the right side, and then texagevimab, silgavimab is again our mouthfuls. But these are the ones that still either haven't been affected by the different Omicron variants circulating, or there are some changes that have thus led to changes with instructions on how to prescribe and how to use and how to dose. But it's important to keep in mind that it's unclear which variants will continue to predominate over time. So right now, I think we're seeing mostly like BA1 or BA1.1, but BA2 is on the horizon, and it looks like areas where it is present, it's been doubling. So it's possible in the future that BA2 might become the predominant one that's circulating. So it's just the big thing here is to just keep in mind, this is what we know right now, but to continue to stay apprised of updates in this area.
Kristina,
yep.
I was just going to say, if it's coming up, don't worry about it. It looks like it's coming up already. There's a question in the chat box that I think you're about to answer.
Oh, yep. So we'll get right into that. So I'll kind of cover high level updates for the three that are still in use right now. Sorry, this keeps not wanting to go forward. So for sotrovimab, it's active against BA1 and BA1.1, but it has reduced activity against BA2. With that being said, it sounds like people are still using it for now. But the key updates with sotrovimab is that It used to be that you could administer it within 10 days of symptom onset, but now they've shortened that duration to 7 days as of Friday. Other key updates that have come out as of Friday are that it's still dosed at a 500 milligram dose as a single IV infusion. This is one where it's a single dose vial and you have to dilute it prior to IV infusion. But if you dilute it in a 50 ml bag, you can now administer that total dose over 15 minutes instead of 30. But if you have an 100 ml infusion bag, you still have to administer over 30 minutes. So this is another recent change that happened, is that the infusion duration is shortened to 15 minutes. Another thing to keep in mind are that this formulation was also designed to potentially be administered through a subcutaneous route, so just as like an IM injection. So there won't be a formulation change, but the subcutaneous administration, it sounds like it's currently under evaluation by the FDA. This came up at a HIV conference a couple weeks ago. But with that, it sounds like it would be 2 4 ml bilateral dorsogluteal injections. It was shown to be non-inferior to IV administration, and it sounds like it was well tolerated. But again, this is under review by the FDA. But again, the ability to use this is probably subject to what variants obviously are circulating later on, but hopefully this does become an option, because just logistically it would be a lot easier to do a shot rather than trying to do an IV infusion. So bebtelovimab, this is the most recently authorized monoclonal antibody. It was just authorized a couple weeks ago, but this is the one that has potent activity against all currently circulating variants of concern, so all the different Omicron subsets. This is one where, again, you have to administer as soon as possible after positive testing and within a total of 7 days of onset. For this one, it slightly differs from sotrovimab in that it's a single IV injection that can be given over at least 30 seconds. So you withdraw the 2 mLs into a disposable syringe, discard the remaining because there is some overfill in there, and then you'll flush with normal saline after you administer the dose, again, after at least 30 seconds. So it's a little bit different administration than the one I just covered. Then Evusheld, just to shorten down, I'm trying to a mouthful of this. This is one where it's more unique in that it's authorized as pre-exposure prophylaxis. So in people with moderate to severe immunosuppression due to either a medical condition or because they're on immunosuppressive medications, if there's a concern that someone might not mount as adequate of immune response, or if you have someone where you can't vaccinate them because they have a history of severe adverse reactions either to the COVID-19 vaccine or different vaccine components, this is where Evusheld is indicated. So it's less active against the Omicron subvariants. It might still have BA1 and BA1.1. It might still have some neutralizing activity against BA2, but again, on Friday, they updated all of this where now they want to double the dose because of this reduced activity against the circulating variants. So if you have someone that's never received any doses of this before, it's now 2 150 milligram doses of the texagevimab component, 2 150 milligram doses of the silgavimab, and all given as consecutive injections. If you have a patient that's previously received just the 150 milligrams of each before, you want them to return as soon as possible to get additional 150 milligram doses of both components as soon as reasonably possible. Because there's larger volumes now going in, the guidance is to try to limit administration to larger muscles of the body, given the larger volume, either in like gluteal muscles, just larger muscles. But this is another big change that just came out on Friday, given the reduced activity that's been seen. So if you have any patients that fall into this category, this is important to just keep in mind if you want to use this as pre-exposure prophylaxis. So then switching over to the antivirals, so these are different from the monoclonal antibodies, right? The antibodies, they're large proteins, that work and bind outside of the virus, right, to neutralize it. The available COVID-19 antivirals, they target viral enzymes within the target cells. So the key 3 ones that we have at the moment So Paxlovid, right, which we'll be talking about a lot with drug-drug interactions later. So that's nirmatrelvir and ritonavir. It targets the main protease, and so essentially inhibits the ability of the virus to mature and kind of produce different proteins. And then molnupiravir and remdesivir both target the RNA replication step, so the RNA-dependent RNA polymerase. They work a bit differently in that remdesivir kind of terminates RNA replication early, whereas molnupiravir introduces mutations over time, so then you get non-functional proteins. But these, in terms of what's currently available right now, these are the three that we have for antivirals specifically. So for an overview of the different outpatient antivirals, just comparing side by side. So molnupiravir is on the left, nirmatrelvir is middle, and then remdesivir is on the right. They're all indicated for, at minimum, adults with mild to moderate COVID-19 and at high risk of severe disease. So again, going back to that list I showed earlier, nirmatrelvir, it's also indicated in, so molnupiravir, it's not indicated in adolescents, I think in part because it is a mutagenic, just based on how it works. Nirmatrelvir and remdesivir can both be used in adolescents as well that are at least 12 years of age and at least weigh at least 40 kilograms. In terms of route of administration, molnupiravir and nirmatrelvir are both orally administered, whereas remdesivir is currently only available in an IV formulation, right? So this is where, in terms of picking out therapies and logistics, obviously an oral medication is a lot easier, right, than doing an IV, but you might have patients where remdesivir is the best option. And I'll show an algorithm on the next slide of how this is currently playing out. And then for dosing, both of the oral medications, they have to be administered every 12 hours for 5 days. They require multiple tablets. So that's another thing that's important to keep in mind and to counsel patients on. And then for remdesivir, for the outpatient regimen, it's 200 milligrams on the first day and then 100 milligrams on days 2 and 3 after that. So which outpatient therapy should you prescribe, right? So this is an overwhelming, right? This is an overwhelming algorithm, but this is updated at least for most of the recent changes that have taken place in terms of therapies that are available. So again, keeping in mind, it's always important to just make sure, if you refer back to these slides, we're happy to share them. But just make sure that you're always checking to see if new updates have happened, because this is a constantly evolving field. But this algorithm, what it's really trying to do is, anyway, help, even though it's cumbersome, it is trying to help a bit to try to navigate what therapies should you be considering, and then different patient-specific factors that kind of feed into that decision process. So again, all of these, it's for adult and pediatric patients with mild to moderate COVID-19 and at high risk for disease progression. But if they're beyond that window of 5 to 7 days, then you have to move on to other treatment of symptoms and management per the NIH and CDC guidelines. If the patient's hospitalized, these are for the most part off the table. Remdesivir is like the one that is indicated for use in hospitalized patients. And there's a lot of work in this area, but these are just big picture things to keep in mind. So if you do, though, have a patient that is not hospitalized, has symptom onset within the previous 5 to 7 days, the first thing that it goes through is, do they have severe renal impairment or do they have hepatic impairment? If yes, then this is where you'd want to consider one of those monoclonal antibodies for use. And they're all pretty effective, either 79 to 88% relative risk reduction in hospitalization and death. The one caveat is with bebtelovimab. This is like a combined basis on totality of evidence and that it works against the circulating variants, but there's not a lot of clinical data with Omicron and how effective it is. But with that being said, it has similar neutralizing activity to other monoclonals, and anyway, should still be of utility, but this is anyway part of what feeds into this. If they don't have renal impairment or severe hepatic impairment, then you can consider really any of the therapies that I covered except for molnupiravir. And the molnupiravir, it's kind of anyway downstream of this decision process tree because it only has shown a 30% relative risk reduction in comparison to the other therapies. But if you have someone where you're really you don't have monoclonals available as an example, they meet the age criteria, and you don't really have any other options except that, then that's a case where you'd maybe consider molnupiravir. But again, timing of therapy is critical. All of these, they work best when initiated, like as soon as possible, but within a maximum of 5 to 7 days of onset. Your therapy choice might be limited by local availability. Obviously, you can't prescribe something if you don't have it. I think some supply chain issues with Paxlovid, as example, have improved. But again, right, you're kind of limited by what you actually have on the table. And then considerations of drug-drug interactions are also important. And then that's what the rest of the talk will be about. So for drug interactions,
if you'd want to answer a couple of the questions in the chat box, I think you did some of them, but one of them came up about the IV mixes. Can they be given anywhere? I guess location on the body and also nursing home versus outpatient and inpatient.
Yeah, so I'm not sure if the IV mixes I mean, was that more about the facility type? Because I think if you have them available, or I'm honestly not sure of the distribution process, and this is on my side. I'm not a clinical pharmacist, like by training I am, but I'm more on the like research side of things right now, so I can't fully speak to distribution wise where everything's where that's happening. But I would assume if you could, you know, administer an infusion in any setting and you had that readily available to you, that you could readily do that. In terms of site of administration, I'd also have to look into that. I mean, generally just the arm, but if you needed an alternative site of access, I'd have to look into that, but I can do that.
Okay, or you might know if it's peripheral versus central IV administration.
I believe it's peripheral. Yeah.
So too.
Yeah, they're all peripheral, but just, I don't know if you can't necessarily get in the arm, if there's any concern with other locations or anything like that, I can look into. A good question.
Another question was, can we crush the antiviral therapies for ease of administration?
So I would have to, I'm not sure if there's any, I know there's not any data with Paxlovid at the moment. I can look up for molnupiravir. That's another good question, and get back to you.
Sure, thank you.
Sorry. Yeah. I know Paxlovid you cannot though. Unfortunately, just there's no data, and I doubt there is for molnupiravir, but I'll double check.
Okay. I think you answered the other ones. Thank you.
Okay. So for the drug interactions with outpatient therapies, big picture, the monoclonal antibodies, there's really no concern of drug interactions there. For molnupiravir, it's unlikely just based on how the drug is metabolized and what's been shown in studies, but there haven't technically been DDI studies. For Paxlovid, as I'm sure you're more than aware, there's a lot. It's can both cause interactions and be susceptible to them. And then remdesivir is another one where it's unlikely to cause clinically relevant interactions. Like there is some data that it can inhibit or induce some enzymes, but at clinically relevant doses and how quickly it's eliminated, it's not clear. Strong inducers could reduce remdesivir exposures, but they don't recommend any type of dose adjustments if you do have someone on that. The only thing you cannot do, I hope no one is doing still, is hydroxychloroquine or chloroquine. It does reduce formation of the active triphosphate that you need for the drug to work. So that is one of the few where they do actively recommend against using that combination together. So we'll focus on Paxlovid. So for ritonavir, this is really the component that is the troublemaker. So ritonavir, it inhibits CYP3A4, which is involved in metabolizing tons and tons and tons of different drugs. Ritonavir can also inhibit different drug transporters and even esterases in the gut. So anyway, there's a lot of different ways that ritonavir can cause problems for you. So as a graphical representation, the blue line, it's showing the concentrations of the drug like in the blood before you add on ritonavir. But once you add on ritonavir, what we're usually worried about is that drug exposures are going to increase, right? And so if they get too high, there's a risk of toxicity. On the flip side, if you give a drug and exposures to the Paxlovid component is reduced, you would risk potentially failure, and you could also risk failure with other co-medications. But then the other question becomes, if there is an increase, is it within a range that we know is is still safe, or do we have a narrow therapeutic drug where even a small increase could create a huge problem for us? And so this is a lot of what we're trying to tease apart here. And another thing that's important to keep in mind is that even though the dosing of Paxlovid is for only 5 days, the effect of ritonavir lasts beyond 5 days. So ritonavir, it's a mechanism-based enzyme inhibitor. So it takes about 3 days to eliminate that inactivated enzyme and make new enzyme. So it's important to keep in mind that if you are in a situation where you have to hold or dose adjust the other medications that someone is on, that you should wait at least 2 to 3 days after stopping therapy before you start manipulating what exactly they're on. So for practical managements of drug-drug interactions, there's a component of overall, it is a short duration of therapy. So this kind of feeds into some of the recommendations that have been made. So the question becomes, if there is an interaction of concern, can you hold the concomitant medication for 8 days? And if not, how likely are the toxicities and how bad are the toxicities that could result? And so the decisions, it's really made on both patient-specific factors and our knowledge of what ritonavir has done, because we use it a lot in HIV. We've tried to extrapolate, what we've seen there versus what we'd expect in patients with COVID. So again, it's kind of a balance of trying to weigh between these. So for a head start on DDI management, it's important to make sure that you're always getting an updated medication list to expedite management and potentially avoid significant toxicities. So you always want to do a complete med rec. This is where your pharmacists are great. You want to take advantage of them if you have them, but you want to make sure you're asking about prescribed medications and even non-prescribed medications, right? Over-the-counter products, dietary and herbal supplements, even recreational drugs. If you have a patient, anyway, where they've had a transplant, they're getting cancer treatment, it's important to have name and contact info of those providers and be proactive about what therapies they're on and how exactly you would theoretically handle, just so you can expedite those conversations. And then make sure that everything's updated as much as possible in the EMR. And if a patient is willing, to also share that list with caretakers or family members so they can be involved in those discussions as well. So this is another fun algorithm, right, for managing DDIs, and this just came out, this was just published yesterday, right? So this is just getting at every day we have new updates, but we'll go through key examples, but this is a helpful algorithm to go through. If you don't expect an interaction, just proceed with treatment. If it's a weak interaction, again, proceed with treatment. But if you have a potential drug interaction, you have to look at, can the drug be withdrawn? Can you dose adjust? And then it kind of feeds through this, yes, you can proceed with treatment, or no, you might want to consider something else. And then that's where side by side, you might consider a monoclonal antibody as an example, or remdesivir treatment over Paxlovid. And then there's some where you absolutely should not co-administer that we'll go through. But again, this is all kind of this decision tree process of how to handle. So you don't have to do this on your own is the good news. So there's a lot of different good free resources available for screening drug interactions. University of Liverpool, I'll show an example on the next slide of using it. It's a really helpful database of almost all drugs available, and it gives evidence for what's been seen and recommendations on how to handle. The COVID-19 advisory for Ontario, they also have really helpful tables and recommendations on how to handle different drug interactions. And then DHHS, the COVID-19 treatment guidelines, they also have, comprehensive resources for navigating these. But again, even though I'll go through examples today, the recommendations are always changing. So please make sure you're using these databases to screen for drug interactions. Again, I'll go through some of these slides quickly because they're just lists of medications, but it's always important to make sure that you're screening through the most up-to-date info available. So this is showing the University of Liverpool website, and this is a really handy website because you can essentially type in the COVID drug that you're considering giving. And then, so if you are considering Paxlovid, please, if nothing else, please screen for drug interactions. You don't have to remember everything, but just always screen for drug interactions. But you can just type the first few letters, it'll pop up, you'll select it. Then you can type in different co-medications, and then it will pop up with whether there's no interaction, a potential interaction, or they'll even have like red alerts of like, absolutely do not co-administer these together. So you can type in multiple medications from the person's list. You don't have to do these one at a time. And you can even export, I think, reports out that'll give an overall summary of how to handle. So this is a super handy, completely free resource. I use it. They also make ones for like HIV and hepatitis C treatment, and I use them all the time, even though those are my areas. So huge advocate of their website. So I worked with Dr. Kaiser. She's another professor in our department, but she was able to get the top 12 concomitant medications that have been searched in the US through the University of Liverpool website. And as you can see, these are the top 12, right, pretty commonly prescribed medications. But the good news is a lot of them, they are okay to use together, right? So these green check marks mean that you can use them together. But for atorvastatin, amlodipine, apixaban, and simvastatin, these are ones that we'll talk about in a little bit more depth. So for a SAFE list, again, I won't go through all of these, and we'll send out slides to make sure that you can anyway review these lists. But these are drugs. So there's like different anticonvulsants, antidepressants as examples that are safe to use. There's no or little interaction expected. And this is from the University of Ontario group. Again, getting at more medications, again, not exhaustive, but just to help kind of guide and give you a general sense of what's working and not. For statins, this is a case where there's either concerning interactions where you can, it's possible you could potentially hold atorvastatin, lovastatin, rosuvastatin, and simvastatin until 2 to 3 days after the last dose of Paxlovid's given. If you have somebody on pitavastatin and pravastatin, they're metabolized differently, so, and there's no interactions of concern, so those can be continued, but the bottom line is generally to hold them if possible for most of the statins. For amlodipine, this is a case where there's a twofold increase in amlodipine exposures, so you can either consider temporarily reducing the dose during treatment, advising the patients to monitor for symptoms of hypotension and then pause treatment if they're symptomatic, or you can consider completely withholding if they are kind of like on the lower end to start and you really just don't want to risk any type of side effects. And it's a similar management strategy for other calcium channel blockers, but bottom line for amlodipine is usually to adjust if you can. For the DOACs, these come up a lot, right? And probably some of the more concerning ones that people encounter. So recommendations, the bottom line is it's complicated. They vary between whether or not you have somebody that with acute venous thromboembolism versus AFib. So for a lot of these, except dabigatran, the guidance is to hold and use low molecular weight heparin in those cases. Dabigatran, you can still potentially use, right, as long as their renal function's okay. For AFib, this is a case where you can either dose adjust for the most part, except rivaroxaban, it's not recommended. And then you want to resume your prior dose 2 days after completing Paxlovid. But again, it's complicated, so just always try to refer back and look up the exact guidance and patient characteristics that your patient falls under. Clopidogrel and prasugrel, they're both prodrugs. Ritonavir is known to decrease these. So prasugrel, even though it's lower, it still maintains adequate platelet inhibition, but not clopidogrel. So this is a case where prasugrel is preferred. If you're not worried about transient loss of clopidogrel, you can continue it. It is, however, contraindicated in individuals within 6 weeks of coronary stent, just because obviously the risk outweighs the benefits there. So again, the bottom line there is if it's closer to when the event happened, you don't want to co-administer those. For antipsychotics, this is another one where if you see an antipsychotic, it's good to just screen and see what the recommendation is, because for a lot of cases, ritonavir is going to hugely increase exposures. In some cases, the guidance is just to monitor, reduce the dose if possible. But as an example for quetiapine, right, there's a potential 5 to 8-fold increase there. So if it's possible to dose adjust, they recommend dose adjusting to 1/6 of the original daily dose. If dose adjustment isn't possible, then you should not use Paxlovid. But the bottom line here is no clozapine to adjust quetiapine or avoid completely. So tacrolimus is another one that I think has come up a lot with transplant patients, and this is still an ongoing debate on how best to handle. So I won't fully go through this, but the bottom line is to just work with transplant. Generally, it seems like people are holding the medication. The time to restart is unclear, but appears to be around day 8. But the thing here is if you can monitor levels and get them back fairly quickly, it's obviously you want to monitor, you want to work with your transplant team, and then you want to restart therapy fast just so they don't risk becoming subtherapeutic there. Chemotherapeutic agents, this is another one where you want to be in touch with the provider. So University of Liverpool, they're working on adding a lot of the cancer therapies into their COVID database. So right now you can use their other resources. So for HIV drug interactions and cancer drug interactions to screen for those until they become available on the website. For the Ontario group, there's some that they say are contraindicated and to avoid. For DHHS, there's again, different kinase inhibitors that are recommended to avoid or to consult with an oncology provider. But again, bottom line, it's complicated and work with oncology. For people with HIV on boosted regimens, no dose adjustment is recommended. For these, the risk of trying to adjust all of this versus just co-administering everything together was just deemed to be too much. But it is important to warn the patient about the potential additive side effects. So more so GI symptom or GI side effects, so it might be a bit more common in those. So it's important to still warn them about it. Paxlovid, it can also be a victim of drug-drug interactions. So it's important to avoid inducers. So there's some anti-cancer agents, anticonvulsants, right? Rifamycins are a problem, St. John's wort. These are cases where if somebody's on these, you can't just stop the drug and the interaction will go away because induction takes about 2 weeks to go away. So you'll unfortunately have to just pick a different therapy out to use if you have somebody on one of these other co-medications. Again, I have other unsafe lists. So absolutely no, do not use together. Some that are hold 'em type of therapies for now. And then a whole list of just to adjust the dose if possible, or minimize use if feasible. But again, important to try to always screen for updated recommendations on these. So in conclusion, drug interactions are really important to consider with Paxlovid, but you've got this. So hopefully these resources and just a general overview have been helpful. But it's important to use these important and free resources. There are a lot available to you. But it's also, again, getting at pharmacists, this is a good time where if you can hire a pharmacist or you can retain good clinical pharmacists, we are your friend. We're here to help. We're here to collaborate. So please use us. And with that, we'll acknowledge anyway all the different people that helped us kind of navigate all of these drug interactions and from these different groups. And then I'll hand it over to Mitchel to kind of go through debunking some of these therapies.
Hi, everyone. So as Dr. Kaiser said, my name is Mitchel. I'm a pharmacy student at the University of Colorado. And I am here to share about controversial therapies. Hold on, I'm trying to share my screen. Can I share my screen through someone? There we go.
Just made you a co-host, so please go ahead.
Appreciate it. Okay, can everyone see that?
I can see it, yeah.
Okay, so I am here to present on controversial COVID-19 therapies and their potential adverse effects. I put the term controversial in quotes because these are the therapies that keep coming up in the public eye that we keep hearing, or people will swear by them that they work, but when you get into the medical evidence, there's very little for it. So, you know, panic breeds ingenuity. Since COVID hit the scene in 2020, late 2019, there's been a whole host of supported remedies or supposed remedies for COVID-19. I won't go through them all. There's no reason to. There's very little evidence of any to support any of them. Everything from durian and mangoes to hot peppers and turmeric. In addition to that, a lot of non-food options have come across the market. A lot of these are non-medical options, but you can see everything from medical herbal remedies, chlorine dioxide, colloidal silver, a lot of different things that can be done. So I'm sorry for the interruption. Can you guys leave for 5 seconds, please? Go. Hi, so the only things that I have, sorry about the interruption. I'm actually in my classroom. I didn't think I'd be presenting now. We start at 1. So you'll note the only things on here that are actually have medical benefit are hydroxychloroquine and ivermectin, which are the two that I will go into in a little more detail with the rest of the presentation. So you'll notice everything possible under the sun's been tried. I pulled these up off the internet. They were offering cow urine parties as a remedy for COVID. Everything on the right from mangoes, mouthwash, even camel urine. So, fear breeds ingenuity. Do you have any football fans, soccer fans in the audience? Leo Messi is a fantastic soccer player, but apparently he's also a bit of a sucker. He paid $1,200 for a COVID-safe bed that supposedly kills the virus within 4 hours. And I don't know why he would do that, but there it is. So back to the pharmacological side, chloroquine or hydroxychloroquine is actually an antiviral medication that was tested for antiviral therapies against COVID-19. The study that was most important was this one done by the New England Journal of Medicine. The primary outcome was a 28-day mortality. It was a relatively large sample size, almost 5,000 individuals. Of that, 1,500 were in the hydroxychloroquine group and 3,100 were in the regular standards of care. You can see from this that 27% of the patients who were treated with hydroxychloroquine experienced mortality, and 25% of the regular group did. As such, we can see that hydroxychloroquine, when it's used, is not really medically beneficial. It doesn't take a lot of statistical analysis to see that when it was used, it didn't really prove a benefit to these patients. A worthy of note is in patients that received hydroxychloroquine, they had a higher frequency of invasive medical ventilation and death as well. So it not only didn't help, it potentially hurt. Ivermectin is the other one that seems to be coming up frequently. It is normally a horse dewormer, which seems the normal place to start as to why people would want to use the horse dewormer to treat a virus. So the MOA for ivermectin per lexicon, it binds selectively and with strong affinity to glutamate-gated chloride ion channels within that occur within invertebrate nerve and muscle cells. This leads to increased permeability of the cell membrane, eventually paralysis and death of the parasite. Viruses, since they are not helminths, do not have glutamate-gated chloride ion channels, and so ivermectin wouldn't really work for them. But wait, you can say, anything is toxic if you take enough of it. What if we just took enough ivermectin? So there was a study done showing that lowest MIC to be effective against COVID was 2.2. Ivermectin at the highest Cmax when ingested, pharmacokinetically adjusting for protein binding, you would need about 367 doses of ivermectin to reach the internal MIC to provide actual protection against COVID. Obviously, when you take 367 doses of things like, I'm sorry, not ivermectin, I apologize. When you take 367 doses of a drug, it's not going to do much good for you. It's going to have a lot of negative, and in the case of ivermectin, there can be some relatively significant side effects. I've listed them here. Things like hydroxychloroquine, some of the more severe ones include the QTc prolongation in case they have severe issues, renal toxicity. For the ivermectin, you're going to have a lot of GI issues, a lot of gastrointestinal nausea, vomiting, things like that. And a bigger issue is when there's a huge push towards one drug without forethought for it, it leads to these unnecessary shortages. And I personally had an issue with this. My girlfriend's mother has lupus. And so when this hydroxychloroquine shortage happened, there was a huge shortage and she was actually unable to get her medication. And it made a huge problem for her for several months. Treatment guidelines as they exist now do not, they recommend against the usage of either of these therapies due to the lack of efficacy and the unnecessary harm caused. I am now done. I would love to answer any questions that you guys have, if you have them.
Thank you, Mitchell. Very, very timely update for us. And I like the way you present the myths and debunking. Yeah, that's a great presentation. Thank you. Let's go ahead and take any questions. We actually have time. Dr. Carrie Levy has agreed to present her part of the presentation next month. So we'll look forward to learning about the NOW network. But if there are questions today for Kristina or Mitchell or anyone else, let's go ahead and ask them.
Singh, this is Greg. I have a quick remark. I don't know how many people on the call know, but there are a group of Republican folks in our state legislature, both in the Senate and on the legislative side, that have introduced a bill not to allow, basically not to allow the medical board or anybody else to poo-poo use of ivermectin or hydroxychloroquine. And it also strips away the medical board's part of their authority to disciplined providers. So, I mean, it's silly, but if you can find the bill online, I think Jenny may have, Jenny, you may have sent that to me, or I don't know where I saw that, but if your local legislators on the list, I've already contacted 3 of them saying, why would you do this? You're losing my votes. Not that they ever had them, but they're losing them anyway. As long as they think they're losing votes, they might actually listen. So.
No, thank you, Greg. I think you're right. I don't know if Kristina or Mitchell have any comments on that.
No, just to reiterate, writing to your representatives to fight against it. I know there are multiple states that are enacting or trying to enact laws like that, though, where no one can intervene if they're being prescribed, and it's unfortunate because I think we all want cheap and effective therapies, right? But not at the cost of causing harm to people. So ongoing,
Yes,
like ongoing battle, but.
One of the questions that came up earlier in the chat box that we didn't address, because I thought it was quite a general question, was just, are these treatments, or how often are these treatments being used? I think they all sound so new, but there's also so much COVID everywhere.
Yeah, I think it just depends again on regional availability, and there is actually, I can share that too with the slides. I think there is anyway a resource where you can type in anyway for Paxlovid at least where are doses available, but it does sound like for the most part that Colorado, Massachusetts, and I think one other state do actually have a decent supply of Paxlovid now. I know locally, anyway, across our state, COVID has kind of calmed down for now, but again, I'm not sure what exactly is going to happen with BA2 because I've seen mixed assessments of how concerned to be about it, just with the other variants that have just gone through. I can't speak, and I think too, Paxlovid, I think they're trying to target at least 2 million doses per month and try to increase capacity over time. Molnupiravir, I was reading, has been kind of sitting on shelves a bit just because it's not as effective as the other available options. The monoclonals, it sounds like for the most part, have been more available, except for Evusheld. I know that one is kind of source limited, and there's been kind of ongoing debates there on how best to make sure that the most vulnerable people are getting access to those drugs. And I think actually Pennsylvania as an example, they did kind of go through this regional thing where they tried to make sure that people from lower income counties and stuff were still getting enough access to these therapies and weren't just kind of being left out to the wind. So anyway, I don't have a great answer on exact numbers, but I think over the next few months, they'll become increasingly available is a big picture thing.
Yeah. And Dr. Eber has a great question. Do we know the availability of the new monoclonal antibody in Colorado? Oh, thank you.
Okay, yeah, thank you. Thank you.
That's the best. I can't say it yet. So it starts with the B.
Yeah, the Bebtelovimab. I'm not even sure if I'm saying that well, but
Okay.
yeah, I think it's becoming increasingly available. And I think Jen Conley, for people I didn't see, she said she's able to get 20 doses this week. I think it's a bit more limited, but over time, hopefully it'll become a bit better. Oh, and I was saying Molnupiravir, because that question came up, that is another one where because they're capsules, but you can't open, break, or crush. So if you have someone anyway where you want to use an antiviral, so you can't get the monoclonals, probably remdesivir would end up being the one that you end up using. Just assuming availability, but the monoclonals work well too if you have access to all 3.
That'd be another way to prioritize. So yeah, thank you very much for the great education. And I'm sure many of us learned a lot. I know I did.
Yeah, thank you. Feel free to reach out with questions, but again, hopefully you all have access to great clinical pharmacists to help you in this transition too, because we do want to help. So
yes, thank you. Yeah, we love our geriatric long-term care pharmacists. And we appreciate all the great work that wonderful group of professionals does for us. And as I mentioned, our annual conference this year, which is coming up in April, we look forward to welcoming the pharmacists and even awarding some pharmacy credits through the ASCP. And so I hope that we can get even more pharmacists involved and more of a collaboration. Yeah, thank you. We had a great time with all of our speakers today, and I'm so sorry we didn't get to you, Dr. Levy. Carrie has agreed to present next month, and so I appreciate that. And hope that the rest of you have a great day. Look forward to seeing you in Baltimore if you're going there, and also at our annual conference here in Denver in April. And we will have another monthly meeting at the beginning of April, and I'll send that information out soon. Thank you.
Take care. Thanks much.
Thank you. Bye-bye.